after a good history, the student should be able to come to a conclusion whether this patient has got a stable spine or an unstable spine. Is there a neurological deficit, partial or complete? And of course, which part of the spine is involved, cervical, thoracic or lumbar. Depending upon whether the spine is stable or not and deficit or not, the examination should be done whether only in lying down position, because sometimes if it's an unstable, whether neurological progressive neurological deficit can occur, then we would not like to examine the spine either in the standing, sitting, or perform movements, or even examine the gait. So having said that right in the beginning, we start with the general physical examination, and it is important not just for the sake of saying no icterus pallor cyanosis, but pallor could be seen, for example, in a metastatic spine, some blood loss going on because of, let's say, GI malignancy, where there is a history of melena. So in history also, we should try to find out the cause of the primary. Icterus, for example, could be seen where a patient on anti-tubercular therapy could develop icterus. Lymphadenopathy, matted lymph node could be seen in tuberculosis, or Hodgkin's can sometimes present with the spinal involvement. Café spots, I'll talk about it later. And just expansion, whether you talk right in the beginning, the general physical, or in the as a part of the measurements, it should be done in the fourth intercostal space to rule out ankylosing spondylitis. Now, a head-to-toe examination, I've made this slide for the postgraduates so that nothing is missed, especially in case of metastasis. If you try to find out what would be the site of the primary, whether on the history or on examination. So if you follow from head to toe, neck, for example, thyroid malignancy, and the history could be a history of hypo or hyperthyroidism, and an examination there could be a mass in the neck. A breast examination, even in the males, one should try to examine the breast, the respiratory system, the abdomen, especially looking for any organomegaly for metastasis, trying to assess for any psoas abscess in tuberculosis, and also examining for the any enlarged size of the kidney or prostate or cervix. Usually we do not examine per vaginal examination, but you can always tell the exam that we have not done it, so that examiner knows that it should have been done. And in the tuberculosis, of course, looking for sites of cold abscesses, and I'll talk about cold abscesses in the later slides. So, and the general physical examination, a café spot for the postgraduates, can you see the cursor on the slide? Is my cursor visible?
Yes, sir, it is visible.
Okay,
yes, it is. Yes,
so you can see the smooth margins of a café spots, like the smooth margins of the beaches of California. So that is in neurofibromatosis, compared to the ragged margins, okay, which is seen in the coast of Maine. Maine is in this part of US near Boston, where it's rocky, the land is rocky, and this is seen in fibrous dysplasia polyostotic. So spine examination, we have to do just like any other region: inspection, palpation, movements, measurements, special tests, and gait. So in the inspection, you should look for telltale signs of spina bifida occulta, the attitude, the deformities, cold abscess, and muscle spasms, of which I'll talk a little bit in more detail in the subsequent slides. However, I would like to close these matter here, especially looking for scars and sinuses, whether they're active or healed, looking for pressure sores, wet sores, and what grade of pressure sores it is. And often the candidate forgets to mention whether the patient has got an indwelling Foley's catheter. So after the inspection, during the inspection, let me go on to the telltale signs of spina bifida occulta. You must look for not only tuft of hair in the lumbar spine, but even it could be in the thoracic or in the cervical spine. So exposure to the back is important. Look for lipomas, look for any dimpling of the skin, and for the attitude in the cervical spine, for example, if it is an active disease of tuberculosis, a child may present with a torticollis or a rust sign, like holding the head and neck, supporting the head with his hands. In the thoracic spine, a spasm in the thoracic spine could give rise to a squaring of shoulders, sort of an attitude like a military attitude. And in the lumbar spine, we have the alderman gait. Because of the spasm in the lumbar spine, the patient is walking like an alderman. Alderman are basically a term used in the US or in Western countries who are the city councillors. So they're walking as if they're highlighted. So after inspection, we come to palpation. Of course, always palpation starts with local temperature and then the tenderness. I'll talk about this in the next few slides. And the deformity, kyphosis, scoliosis, horizontal kyphoscoliosis, and I'll talk in details about cold abscess later. So palpation, one should check for direct tenderness by palpating the spinous process. However, it is very important, especially in tuberculosis of the spine, where there's a paradiscal involvement, to give an indirect push on from one side of the spinous process, thereby rotating the spinous process and thereby eliciting pain if the disease is in the anterior part of the spine. And you can see that in this next slide, the same patient with the kyphotic deformity, there was no muscle spasm, but at the time of eliciting the tenderness, a muscle spasm appeared. So this can occur in an active disease of tuberculosis. It's very important for the postgraduate to mark the spinous processes, especially with a good skin marking pen, so that the examiner knows that he has done this exercise. And one can identify the vertebral level either from proximal to distal. From the proximal, the first prominent spinous process T7, known as the vertebra prominence. However, the T1, thoracic 1, is more prominent than C7. So sometimes one can miss the C7 and think that the T1 is the C7. So you have to be careful about it. The landmarks of the scapula, the spinous process at T3 and the inferior angle of scapula at T7 are important, but since scapula is a mobile structure, it's very important that the patient, while examining, should have the limbs by the side and not move. If the upper limb is abducted, then there could be a false leveling because of the movement of the scapula. So the distal part, a very good landmark, is the highest point of the iliac crest, which corresponds to the L4 vertebral body. Regarding the deformity, the postgraduate should be able to tell whether it's a knuckle, the single vertebral involvement, or angular 2 to 3, or rounded. Single vertebral involvement could be seen in a eosinophilic granuloma. Metastasis can have single, angular, or rounded anything. Lymphoma usually occurs in single. A central type of tuberculosis, which is quite rare, can cause knuckle deformity. More commonly, tuberculosis causes 2 to 3 vertebral involvements and angular deformity. Metastasis can also have the same thing. And rounded can be seen in Sherman's disease or a senile kyphosis because of old age. Deformity of scoliosis, one should be able to know whether it's a postural scoliosis and whether it's just a scoliosis or is it a sciatic list, and the scoliosis is structural or it's non-structural. Various causes of structural scoliosis are there, and one very easy method of differentiating is ask the patient to bend forward as if to touch the front of his foot and ankle. So if it's a non-structural scoliosis, then the spine deformity will disappear. If it's a structural scoliosis, the deformity will persist. One can also do this while making the patient lie prone. If it's a young child, very small, then even the child can be lifted by the chin, just like in the Russ sign, that sort of a support. And if it's a non-structural, the spine straightens out. That's only for a very, very young child. For the cold abscesses, very important for the postgraduates to know, in the cervical spine, it can present anywhere in the triangles of the neck. In the thoracic spine, it can go. So what is cold abscess? Cold abscess is basically all the debris from the tubercular spine, which is more common in the paradiscal, as I said before, and all the granulation tissue and the debris and the pus, which tracks down along the lines of least resistance. So it may gravitate down, or it can follow the neurovascular bundle or the interfacial planes. So it can follow the nerve root and go in the paravertebral area. It can follow the intercostal nerve root and go along between the two ribs till the middle or the anterior axillary fold. It can even follow anteriorly in the anterior chest wall. And a very favorite question to the postgraduates is whether a psoas abscess can be, can occur in a patient with a high, like T5 or T6 tuberculosis. So For that, we have to understand the anatomy. The prevertebral fascia is attached to the T4. So all the abscesses due to a cervical spine tuberculosis is limited to the up till T4 itself, but T4 downwards, the abscess may track, gravitate along the aorta, and through the openings of the diaphragm could go into any of the regions I'm going to talk about. So one by one, along the lateral arcuate ligament, this is the lateral arcuate ligament, it can come along the quadratus lumborum, it can go behind the kidney, it can go from there along the 12th thoracic or the ilioinguinal or iliohypogastric nerve onto the anterior abdominal wall. It can go along the medial lumbocostal arch or medial arcuate ligament to the psoas sheath and go down as a psoas abscess. It can go along the median arcuate ligament which crosses the aorta, and along the aorta, it can go into the abdomen along any of its branch. So it can go from the internal pudendal artery even up till the ischiorectal fossa. It can follow the superior gluteal artery to the buttocks. I remember 2-3 months back, a patient came to our orthopedics ward referred from surgery because there was an abscess in the buttocks and they had done an IND, and later it turned to be a cold abscess from the spine. So the cold abscess can go along the sheath of the psoas or quadratus lumborum. It can follow the lumbar nerves. It can go up to the femoral and obturator nerve into the thigh. It can go on the back. It can go from the sciatic nerve. Theoretically, it can go even as far as the popliteal fossa, or even follow the nerves to the toes, though I have not seen one onto the toe. Intermuscular plane, the Petit's triangle is another favorite question we asked the so this is the psoas abscess, and for the triangles, there are two important triangles for the students to know. One is the superior lumbar triangle, which is bounded by the T12, and then you have the internal oblique here, and then the quadratus lumborum. And for the Petit's triangle is the iliac crest, the latissimus dorsi, and the external oblique. So these two areas from the interfacial planes, a cold abscess may track down and must look for them during the palpation. So different sites of cold abscesses could be there. Regarding movements, as I mentioned before, you must tell the examiner if the patient has got an unstable spine or a neurological deficit that you have not done the movements and would not like to do the movements. However, in an unstable spine, if it's a cervical spine pathology, if it's a stable spine, then you can do the movements, various movements of the spine, cervical spine, various movements of the lumbar spine. Here, I would like to highlight about the thoracic spine. That in the thoracic spine, the most important movement is the rotation, because the other movements are restricted because of the rib cage, and the rotation, which can be observed by making the patient sit on a stool or a chair and rotating from the right or left, the patient will have pain. So that could give a clue that it's a thoracic spine pathology, like a tuberculosis of the thoracic spine, which is anteriorly paradiscal but creating a pain on movement, rotatory movements. Regarding the measurements, various measurements are there. For the ankylosing spondylitis, to know the excursion of the spine movement, the Shover's test, and the modified Shover's test, various books describe it differently. So basically it is when you draw a line along the dimple of the venous and take up to 10 centimeter proximal or the modified 15 centimeter and ask the patient to bend forwards, there should be an excursion of 5 centimeter during the normal movement of the lumbar spine. Whereas if there is a restriction of the movement, it will be less than 5 centimeters. The other movements, which is very important, especially for recording the progress of a disease of ankylosing spondylitis, could be the chin-brow vertical angle, which normally should be 0 degree, but in a patient with kyphosis, it would be progressive in ankylosing spondylitis. Similarly, a normal person, the occiput should be able to touch the wall behind, but if there is a deformity and progressive, then this wall test would be positive. Head occipital, the occipital wall distance would increase. Similarly, the distance between the tip of the fingers and the floor from the front or from the side could give an assessment of the amount of restriction of the spinal movements, forward or lateral flexion. Regarding the gait, Dr. Kapoor would be talking about gait. However, I'd like to talk a few things here. One is the simian stance. Okay, so the Seaman stance is seen, Seaman is ape-like, so that is a forward stance which is seen in lumbar canal stenosis. And the other thing I would like to talk about is the sciatic list. So usually the disc is, it's not a far lateral disc, okay? So the axillary presentation of the disc, if it's irritating the nerve root, the patient will turn away so that it gets relaxed. Whereas if it's a shoulder presentation, which is irritating near the shoulder, right? Sorry, I said it the other way around. So if it's an axillary presentation here, the patient will turn on the same side so that the nerve root gets relaxed. If it's a shoulder presentation, then the person will turn the opposite side to relax the nerve root. Special tests are there for the disc prolapse and the SI joints, and quickly I'll go through them. The Lassig's test, also known as the straight leg raising test, is by raising the lower limb one by one. It's important to raise on the side where the neurological symptoms of radicular pain is there. So if you raise the limb on that side, between 30 to 70 degrees, it is positive to show a positive SLR. And this is not the correct way of the Lassig's test, where you flex the hip and knee and then extend. However, some literature do mention about it, but we generally talk about this way. And when we perform the Lassig's test, it's important, it should not be just a back pain, it should be a radiating pain along the nerve root. And the sensitivity of this test is 91, but specificity is better if it's a cross SLR, where the patient may be complaining of pain radiating on one limb, but on raising the opposite limb, there is a pain. So that is seen in a large disc, a central type of disc. Then we have the Bragas test. So in the SLR test, we just lift the limb, and where the pain has appeared, you can just flex the knee a little. Whereas in the Bragas test, we dorsiflex at the point where the SLR was positive, you decrease you bring down the limb a little and then dorsiflex the ankle. So that would again stretch the nerve root and cause the pain. Then the bowstring stretch test, where after doing the SLR, you bring down the limb a little and then you press on to the lateral popliteal nerve, and that will cause increase in pain. So these are the special nerve root stretch tests in case of PIVD. For the femoral nerve stretch test, you need to keep the patient prone. This is more important for the disc prolapse, which is rarer in the L2-3 and the L3-4. So classically, the SLRT was described for the L5-S1, and this is known as a reverse Lassig's test. Test for SI joint, the various tests, let's look at them one by one. The flexion, abduction, or external rotation of the Patrick's test is by stabilizing the pelvis on one side and doing the flexion, abduction, external rotation. Then we have the Gansland's test, where we flex the opposite side, and the side to be tested, we get the patient to the side of the examination couch and take the limb off the couch and do an hyperextension of the hip. So that would cause a pain at the SI joint. And then some examiners also like to know about the pump handle test, where we take flex the hip and knee and take it towards the shoulder, and that will cause pain. So I think, yeah, so that's about the presentation. I try to do it in 12 minutes. I hope not exceed much time. Yeah, thank you.